Okay, great. Well, this has been a long time coming. We've been trying to organize Dr. Akira Ishiyama over at UCLA to come give us a talk. He is professor of otolaryngology and neurootology at UCLA, and he did his undergraduate degree at MIT in physics, graduate studies also in physics, and then went on to Northwestern for his medical degree, and then did his training at UCLA and over at Vanderbilt. So we are so happy that he's joining us to be talking about imaging and histology of endolymphatic hydrops. It's something that we see patients coming with their MRI studies, and I'm personally very interested to learn more about this technique. And so welcome, and we look forward to your talk.
Thank you very much for, again, for this invitation. We became interested in Meniere's disease some time ago. As you know, we have one of the active temple bone laboratories from using postmortem tissues. In 2016, we are fortunate to receive the funding from NIDCD, and our temple bone histology lab is designated as the NIDCD National Temple Bone Laboratory. And we collaborate with anybody who are interested in using the human archive temple bone specimens. And so you guys are right down the street. So if you have any interest to collaborate using a specimens, you're always welcome. And we have enjoyed having some of your graduates from USC Medical School who are now in a residency program, and some of them have done remarkable research projects in our lab. So again, thank you for giving me the opportunity to talk to you this morning. First of all, as you know, Prosper Ménière defined this disease in 1861, and ever since, it remains a mystery as to what this disease is all about. And the initial temple bone histopathology work was, the first study was done in Japan, Osaka, Japan in 1938. This paper was published in German language. And the chair of OB/GYN department at the Osaka University had a very severe case of Meniere's disease. And it was his wish to have his temple bone studied. Upon death, and the chief of otolaryngology at the Osaka University harvested his temple bones and demonstrated that indeed the underlying histopathology was endolymphatic hydrops. 6 months later in England, Holpike and Carnes, after they did 2 vestibular retrosigmoid vestibular neurectomy, 2 young patients actually passed away right after the surgery. And in those days, it was much easier to obtain postmortem tissues, and they studied the temple bone histology and found exactly the same finding, which is the endolymphatic hydrops. Now, it has been stated in the previous studies that the sensory end organs, such as the hair cells and the hair cells from the cochlea and the vestibular end organs, are normal. So as you know, using the diagnostic criteria for Meniere's disease, rotational vertigo, fluctuating hearing loss, tinnitus, earfulness, duration of vertigo more than 20 minutes on 2 separate occasions. But the question is, why is it that we develop this condition? And is there any way that we can determine the presence of hydrops or endolymphatic hydrops in a patient when a patient comes into the office? Is there any way we can actually diagnose it reliably? So that's one of the motivations why we began to investigate the possibility of imaging the inner ear for patient with a Meniere's disease or somebody who is suspected to have Meniere's. The original study was done in Nagawa, Japan by Naganawa around 2012. And the first study was to inject the gadolinium transtympanic and waited 24 hours and created a phase contrast between the perilymph and the endolymph. So this picture indicates the yellow is indicating the endolymph, and the blue is the perilymph. And this is where the stapes is. And for the residents, and one of the contraindications for stapedectomy is endolymphatic hydrops. The reason being, distension of the circular membrane could be directly under the stapes foot plate. So when you manipulate the stapes foot plate, you can potentially rupture the circular membrane, and the mixture of endolymph and perilymph could result in profound hearing loss. Now, if you're able to reliably place a contrast in the perilymph and create a phase contrast between the endolymph and the perilymph, then you can visualize what's happening in the inner ear. So if you use the direct inner ear imaging, such as cysternographic T2 weighted image, both the perilymph and the endolymph are bright, and it's very difficult to see anything there. So the first thing we initially did, now we're going back almost 8 years ago. After the first study came from Japan, we said, well, is it true that you can actually see diffusion of contrast in the inner ear? So we put the gadolinium in the middle ear and asked the patient to keep in this case, we injected the right ear, and we asked the patient to keep the left ear down for about an hour. And then 24 hours later, we did the traditional MRI studies. And as you can see the diffusion of contrast in the inner ear, and obviously you don't see anything on the left. Prior to injecting this material going backwards, now we're going back at almost 20 years. We had a strong interest to use, again, high concentration, higher dose of gadolinium to see whether that would allow us to visualize the inner ear. And in the guinea pig model, when we injected pretty high dose of gadolinium, you could see the phase contrast between the perilymph and the endolymph. So 20 years ago, we used the upper limit of FDA allowed gadolinium concentration at the time and captured the image, but we didn't see anything. So we have given up at the time. Then 10 years passed. And then with the gadolinium transtympanic injection, you can see the diffusion of contrast. This is how it looks like on the FLAIR, and you can clearly see the image with a contrast enhancement on the right side. And if you do a 3D FLAIR, obviously it gets the conspicuity of the contrast increases. So if you compare the appearance at the T1, 2D FLAIR, and space FLAIR, or the 3D FLAIR, you can see the progression of contrast diffusion in the inner ear. And then if you allow a 3D FLAIR, you can begin to see the phase contrast between the endolymph and perilymph. For example, on the right-hand side, this dark area is where the endolymph is, and that area is surrounded by perilymph. So this is another example of a 3D FLAIR where you can see the enhancement, in the perilymph with the endolymph in the center. And this is the corresponding image on the left side. And then if you apply the multiple inversion time FLAIR imaging, and you subtract the bright perilymph from dark endolymph, then you begin to see much more. You can see the definition of endolymph containing space and perilymph containing space clearly. For example, here on the right side, you can see the definition of endolymph containing space on the cochlea. Then you can see the vestibule right here. Now the trick is to use slightly higher dose of gadolinium, usually twice the upper limit of what we use for regular MRI. And then now we know why we couldn't see the inner ear 20 years ago when we were using pretty high concentration of gadolinium, because you have to wait 4 hours. So it's a delayed contrast study. We wait 4 hours from the moment when the patient receives the injection, wait 4 hours, and then we place the coil at the directly over the ear. And radiologists, we had to actually spend about 5 years really changing all the parameters to be able to capture the images. So the pictures on the right over here on the top and the bottom indicate how the hydrops looks like. So on the right hand side, you can see pretty remarkable distortion of cochlear. The corresponding side on the left doesn't show much of anything. And this is the area of the vestibule. And if you go much more inferiorly, you can begin to see where the saccule is located. So at this point in time, we can reliably show if the endolymphatic space is dilated. We can say whether the cochlear duct is dilated, saccule is dilated, or uticle is dilated. So this is again another example of left cochlear hydrops, and the right-hand side is the normal cochlea. So you can clearly see the distension of endolymphatic containing space in the cochlea. So when we capture the images, we usually obtain images at the 3 different levels. One of them is at the lateral canal level, and then we capture images at the saccule, and then the cochlear basal turn. Then we analyze. And we have found the imaging to be exceptionally useful, and we haven't yet found a case where patient meets the clinical diagnosis of Meniere's disease and we didn't see any change on the MRI scan. This is one case which I thought was very interesting, and we published this in the American Journal of Neuroradiology. We mainly publish these studies in the radiology journal. Now we're beginning to send papers to the Otolaryngology journal. The reason being, we wanted to make sure that our radiology colleagues would agree what we are doing. So this is one case where a patient had a very severe case of Meniere's disease, and when a patient had active symptom Meniere's, we did the MRI, and as you can see pretty remarkable endolymphatic hydrops in the vestibule. And we put the patient on a Diamox, 250 milligrams once daily. And then within a couple of days, he began to notice that the ear fullness was improving and hearing began to improve. And then a couple months later, we repeated the MRI, and now you can see resolution of hydrops. And this corresponded with improvement in the audiogram as well. So we had 6 or 7 patients who actually demonstrated significant improvement in the diuretic. And unfortunately, as we all know, most of the patients, whether they take diuretics or not, doesn't seem to make much of a difference. But we do seem to have a group of patients who seem to respond to diuretic. And then since the patient was getting better, patient decided to stop taking a diuretic, and then the vertigo returned, hearing dropped, and when we repeated the study, we could see return of endolymphatic hydrops. So in some cases, the hydrops could be a dynamic process. What's interesting is that when you do the intravenous gadolinium enhanced 3D FLIR images, this was actually initially noted by Yamazaki et al. 2012. And when you put the dye in the contrast, when you put the gadolinium in a vein and obtain the images, you can see tremendous enhancement, in this case, in the inner ear, and even the contralateral ear, asymptomatic contralateral ear appears to have enhancement of the contrast. So we decided to study this using patients who had Meniere's disease and the sudden hearing loss, using medulla as a control. And what we found is, this I think is extremely interesting. When a patient has Meniere's disease, there is a remarkable uptake of contrast in the inner ear. And even in the contralateral asymptomatic ear, the contrast uptake is significantly higher compared to the patient who had MRI for sudden sensory hearing loss. And then we became interested in what could be the underlying reason why you can have such an enhancement of contrast uptake into the inner ear. And we began to start looking at this issue. And then, quite similar to blood-brain barrier, there is a structure called blood labyrinthine barrier. And it is located for the vestibular system within the stroma, where the capillary and the blood vessels come in contact with the stroma, and also modiolus and the spiral ligament and the spiral limbus. And those are the areas known to have blood labyrinthine barrier. So we wanted to look at the microvasculature at these locations. So some of these patients who have very advanced Meniere's disease end up going through labyrinthectomy. And we have been collecting the vestibular end organs from these patients for the last 20 years. And these usually discarded tissues we find to be exceptionally useful. For example, this is a autopsy specimen from patient who didn't have known inner ear disorder. And this is how the vestibular end organ looks like. And the B and C from patient who had Meniere's disease. And strikingly, the findings are very similar. Although the initial studies demonstrated that in Meniere's disease, there are no remarkable pathology of the end organs in the cochlear and the vestibular structure, we have to remember that these traditional archive temporal specimens are embedded in 20 micron thick celloidins. And 20 microns are pretty thick. So if you have some cytoarchitecture abnormality or changes, unless you cut these specimens thin, you're going to miss them. So these are 2 micron sections. And as you can see in B, there is a tremendous edema in the stroma. And you can see distension of capillaries within the stroma. And you can actually see that here as well. And the other interesting thing is the basement membrane uniformly is extremely thickened. And we just don't understand why this happens, but this is something that we find consistently when a patient has Meniere's disease. So we investigated this at the electron microscopy level, and then what we find is pretty interesting. There is a very remarkable thickening of the perivascular basement membrane, as you see over here on the B. And in some of the cases, you can see very severe degenerative changes of the vascular endothelium, and the parasites also seem to have abnormalities. And in some of the cases, these parasites almost have the appearance of migrating macrophages, and some have looked at the possibility of parasites transforming into macrophages, and these are issues that we're particularly interested to find out what's going on. And then we stained these tissues using immunofluorescence. We wanted to see what's happening, and what you see here, A is normal, meaning patient who, these are the autopsy specimens from a patient who passed away with a known immune disease. And the B is a surgical specimen from a patient who had Meniere's disease. And this is the staining of isolectin-4 in green, which basically stains the parasites. And as you see here on B, when a patient has Meniere's disease, we found that parasites disintegrate. And then the next thing we looked at was to see the expression of INOS, inducible nitrous oxide synthase. And A is a normal, and B and C are from patients who have Meniere's disease. And as you can see, there is almost a very minimum expression of INOS in a normal, but when a patient has Meniere's disease, you have a remarkable upregulation of INOS. Then when we look at the endogenous or eNOS, nitrous oxide synthase, it doesn't really seem to make, it doesn't seem to be any way different. Then we looked at the nisotyramine staining, which indicates the presence of direct tissue damage. And A and A1 is from patient who had, these are surgical specimens from patient who had acoustic neuroma. So we obtained these tissues from a translabyrinthine approach. And the B and B1 is from patient who had Meniere's disease. And the red dots indicate where you see the reaction. And the B1 is in the higher power view, showing a reaction in the sensory epithelium, vascular endothelium, and also in the stroma. So in Meniere's disease, clearly there are damages occurring at the vasculature level. And to summarize what's happening at the microvasculature level, tight junction in most of the cases appear to be intact, but there is a remarkable thickening of the perivascular membrane. And you can see these abundant vesicles of luminal presentation in this manner. And you can see retraction of parasites and the disintegration of vascular endothelium. These are quite consistent finding, and that explains why we get the diffusion of contrast from the perilymph into the endolymphatic space. Now the question is, what is the underlying pathology that triggers this event? And this is something that we don't really know, and there are probably multiple reasons to explain this, and further work needs to be conducted in this area. Now, we found this, our imaging technique, to be extremely useful in other conditions. For example, we had a patient who presented with a clinical diagnosis of Meniere's disease. And when we conducted the study, as you can see over here on the right-hand side, you can see distension of endolymphatic space in the vestibule and the cochlea on the left. And if you look at the images across the internal aortic canal, you can see neuroma, very small neuroma from the cochlear nerve. This patient was placed on Diamox, and we continue to monitor this patient clinically. And so far, tumor has not grown, and the patient has been very stable. So when a patient has signs of vestibular, when a patient has vestibular on the MRI, it's a small lesion, and a patient has vestibular symptoms, as shown in the previous histopathology slides, presence of endolymphatic hydrops with acoustic neuroma is not that uncommon. Therefore, it's not an automatic indication for surgery, because that could be potentially controlled. And in some of these cases, you can just follow the patients using medical regimen. Now, this is something that we found to be extremely interesting, and this will be published in Otology and Neurotology very shortly. This paper has been accepted, it's in print. So we have done this technique to probably close to 1,500 or even 2,000 patients over the last 6-7 years. We recently started looking at some of the cases where a patient has, for example, isolated cyclohydrops. Meaning, when you do the MRI scan, the only finding is distension of cycle, and the cochlear duct is completely normal, and you don't see any changes in the uticle. So we wanted to see what we can learn from these cases. So we had actually 18 patients in our database who had isolated cyclohydrops. And out of those 18 patients, 16 patients met the criteria, clinical criteria for Meniere's disease. Out of those, 12 patients had definite Meniere's, and the 4 patients met the criteria for delayed endolymphatic hydrops. And 1 patient had a history of profound sensorineural hearing loss and developed recurrent episodic vertigo spells 3 years after MRI. And 1 patient had a history of profound sensorineural hearing loss and a traumatic falls at the presentation. One of the things that they were beginning to look at is some patients, although they present with isolated cyclohydrops, or in other cases, you can actually present with isolated cochlear hydrops, over time, some of the patients begin to show progression of hydrops. We had a patient who initially presented simply complaining about earfulness, and the audiogram really didn't show much of abnormality, but on the MRI, we found abnormality. So we followed this gentleman for the last almost 7 years, and slowly he demonstrated hydrops. So we initially thought the patient had eustachian tube issues, but he didn't get better with the conventional treatment for eustachian tube. But now we know that he was developing a hydrop. So in those cases, the imaging study is extremely useful. So again, we capture the images at the 3 different levels as we discussed. So this is such case where a patient has isolated cyclohydrops, that you can see on the right-hand side, and this is the contralateral side. And the top 2 pictures indicate the delayed post-contrast T2 FLAIR images. And when you do the subtractive images, this is how you look, how the tissue looks like. And this is the corresponding T2 weighted images. So in this group, 4 patients had classic Tomarkin crisis, and 83% or 15 patients had mild to severe hearing loss upon presentation. And about half of the patients had ipsilateral caloric paresis. And when we looked at the abnormality of the VEMP, 33% of the patient had reduced or absent VEMP. In this group, all of the 18 patients reported ipsilateral hearing loss, and 72% of the patients demonstrated hearing to fluctuate. 33% of the patient had presented with a sudden hearing loss, and 89% of the patient had tinnitus, and 72% had ipsilateral ear fullness. Now, what's interesting to me is you can actually have MRI finding demonstrating hydropic changes of the saccule, but clinically, it looks exactly the same as Meniere's disease, where you can actually have hearing to fluctuate, you get rotational vertigo lasting more than 20 minutes, at least on 2 separate occasions, tinnitus, and ear fullness. And when you look at the histology, for example, Ruth Gassen at UCLA a long time ago published a paper looking at the isolated circular hydrops presenting at the Meniere's disease. So I think this imaging technique is telling us something about perhaps the underlying disease process. So we still don't know why you can actually have isolated circular hydrops and you can manifest clinically as full-blown Meniere's disease. And I've been thinking about this quite some time, but I don't really have definitive answer to this. But histologically, quite different from the uticle, saccule has 2 arterial supplies and 1 venous outflow. And that I don't think is an explanation, but some have stated that perhaps that might be one of the reasons, but I'm not sure whether, whether that really makes any sense. Now, most of these patients, but not all of them, had moderate to severe hearing loss, but some patients have only limited hearing loss, 18 decibel or less of a hearing loss in the low frequencies. So it's sometimes, unless you have this imaging technique, we might be missing some of the patients with a Meniere's disease using the current clinical criteria. So it might be that in the coming years, once this technique becomes more available clinically, this would be one of the diagnostic testing of choice to confirm the presence of endolymphatic hydrops. So if you look at the audiologic and the vestibular testing data, this is how it presented. The affected side clearly has reduced hearing, and the SRT was also diminished, and the speech discrimination score was also quite different, and the caloric was also reduced, and in some cases the VEMP had abnormality. So to summarize the clinical finding, all these cases where a patient had isolated circular hydrops, they all had vestibular manifestations. And nearly all of the patients had a past or a present history of recurrent spells of spontaneous rotational vertigo. And 4 out of 18 patients, there was no specific dizziness described as a sensation of rocking or simply being off balance. And in these cases, we found our MRI scan to be particularly useful to identify the presence of endolymphatic hydrops. So to conclude it, high resolution delayed contrast MRI demonstrates that Meniere's disease is clearly associated with endolymphatic hydrops in vivo. Now, regional isolated circular hydrops can be associated with the full syndrome of Meniere's disease, and it's possible that this is where we see the disease to start, although we don't have any definitive proof, but it's very suspicious that cycle is where we see the changes for the first time. And it appears that although we don't know what triggers the underlying changes, there is clear disruption of a blood labyrinthine barrier when a patient has Meniere's disease. And in histology studies, it appears that oxidative stress pathway is playing a role in the damage to the blood labyrinthine barrier. So this is, what I prepared for this morning, and we wanted to have, I kept some time to have a discussion with all of you, because I know you guys are extremely talented and experienced in hematology, so we wanted to bounce off some ideas. I'm open to answer any questions you may have.
Thank you so much, Akira, for this great talk. It's such important work. I know all of us neuro-otologists face this difficult disease and are often frustrated with the patients not being able to answer their questions about what causes Meniere's disease, how we can help them relieve their symptoms. Does anyone have any specific questions? Is the MRI technique that you use, do you routinely get that in all of your patients when you're working them up, or do you just select the ones that you're not quite sure about? How do you utilize the great technique you've developed in your own practice?
When we have a high suspicion that the patient has Meniere's, we usually order this. When a patient presents with, for example, there are situations where you cannot really distinguish whether the patient has vestibular migraine or migraine variant, and sometimes migraine and the Meniere's seems to overlap. In those cases, we get the imaging studies to see whether this is due to the endolymphatic hydrops or primary component is from the migraine. When a patient, for example, has acoustic neuroma and begins to develop, we're not talking about big tumor, but small intracanalicular tumor, and a patient has signs of vestibular problems, we get the studies, we get this MRI protocol to see whether there is presence of endolymphatic hydrops. When we have some unusual cases, for example, we had a gentleman who took Cialis, and within 24 hours, his hearing was remarkably diminished and didn't respond to steroids. And we did the MRI studies and showed that cochlear hydrops, and we published that recently. In those cases, we found this, we found this protocol to be extremely useful. The other times that we found this technique to be useful is cases such as a trauma, when a patient presents with perilymphatic fistula, for example, following a head trauma. You can actually see the presence of mixture of endolymph and hydrop, a mixture of endolymph and a perilymph, and most likely it's due to pure lymphatic leak, and you can actually clearly see it. So we had a couple cases like that. So those are the situations we order the scans.
I had a question for me. No, Shama, that was a great talk. This is Uttam Sinha.
Yes.
So I had a technical question. Have you tried changing the field strength? Like is there any difference between 1.5 or 3 Tesla versus other strength?
That's a very good question. So we have not tried 1.5, but I know there are a couple of centers trying to utilize 1.5 Tesla, and also other centers are using much lower dosage of gadolinium concentrations. So I don't have any personal experience, and I just received a paper to review utilizing 1.5 Tesla study. So, but we don't have any personal experience. But those are things that I think people are beginning to investigate. That's a great question.
Yeah, we are. The reason I asked because we are. We at USC we just got a machine. It's a high performance low field, which is 0.5 Tesla machine and that seems to be working out very well in terms of when there's a phase difference in liquid versus solid to air versus liquid. I think that's something to explore. I think the definition of perilymph and endolymph would be much more clean and more sensitive and specific. Sensitivity and specificity may go up probably with the low field high performance MRI.
Yeah, you might be right. Thank you for that suggestion. That's a great idea. Some people have always looked at higher, Tesla translating to better resolution. That's true, but the problem is when you begin to use extremely high Tesla, any kind of movement, such as even the blood flow, breathing, they translate into artifacts. And so you're right. If you could do a better phase contrast with a 1.5, that might be something to investigate. That's a great idea.
And we'll have 0.5 now, so that would be even better probably. So we'll see.
Sounds good.
Okay, thank you.
I have a question, Dr. Ishiyama. Seiji Shibata.
Hi.
Hi.
You graduated from Iowa.
Yeah, exactly. How similar is the blood labyrinthine barrier to the blood-brain barrier? How similar is it physiologically and anatomically?
It's very similar. But the concept of blood labyrinthine barrier in the inner ear has not really been studied at all. But if you look at the underlying histology, it's remarkably similar. And this was initially worked up by Kaga and Suzuki in animal models, but nobody had really studied this in a human. And I think this is something that we think is a very important area to study for a variety of reasons, including Meniere's. If you look at the noise-induced hearing loss in animal models, you can see disruption of a blood labyrinthine barrier. So I think this is something that that requires more attention.
So if it's really similar, so with a lot of systemic inflammation, you see permeability or changes in the integrity of the blood-brain barrier in, for example, meningitis. Do you think same thing with the inflammation occurs in the blood labyrinthine barrier?
It's very likely, yes.
Yeah. And then there are like certain drugs like mannitol that increase the permeability of the blood brain barrier. Do you think that would happen in the blood labyrinthine barrier as well?
I have no idea. I don't know the effect of mannitol. I don't.
Yeah, it would be, I guess, kind of interesting to see if there's any kind of effect of mannitol. I mean, because it's a diuretic, right? And so if you use that, you'll have some kind of effect on, I think, Meniere's disease. Well, anyway.
One of the things that we have found, which I think is interesting, is some of the patients who have COVID. We have seen a couple cases where a patient developed, clinically, they look exactly like Meniere's. And we haven't captured the images yet. But I know of a case from New York where 18-year-old, this patient ended up passing away. But right before she passed away, it was indistinguishable from classic Meniere's. She had severe fullness in the ear, and the hearing dropped, and the hearing began to fluctuate, and then she had recurrent episodic vertigo spells. And as I indicated, the blood labyrinthine barrier is present at the spiral limbus, and at least in the animal models, the binding receptor, ACE2 receptor, appears to be present at the same location. So there might be, the virus might be doing something in these cases. It may be.
It's so interesting you say that, Akira, because I have two patients that, I never could prove, but they had COVID, recovered fine, and during their COVID had sensory neural hearing loss. Now, only unilaterally in both patients. And so you can't ever say, well, you can't distinguish that from idiopathic sensory neural hearing loss. But I often wondered, gosh, the correlation of the timing there must have had some effect on the inner ear. No way to prove that, obviously, while they're still alive. But
yeah, this is something we don't know, but when you look at the literature on the inner ear involvement due to COVID, it's all over, and we don't really have any good understanding. But when you interview these patients who recover from COVID, we clearly have a subset of patients who have either tinnitus or they report change in hearing. And some of the patients I haven't seen many of those cases, but only small numbers at this point. But some of the patients seems to have high frequency sensory hearing loss. But even with a normal audiogram, some patients seems to complain inability to hear. So I wonder whether this is similar to what Charlie Lieberman described as hidden hearing loss, with synaptic changes at the hair cell level. So I think this is something that we all need to work together to see what exactly is COVID doing to the inner ear. But clearly, it appears to be doing something.
Probably all related to the cytokine surge with the inflammatory process, probably.
Yeah, that's a possibility also. But now the question is, there are some isolated cases of virus being detected in the CNS. So I don't know whether it's a primary phenomena due to the viremia. And then the question is, does the virus get into the CNS from the olfactory bulb, or as you indicated, it's a cytokine media pathway, or somehow viremia results in virus to enter into the inner ear directly, or through the eustachian tube pathway into the ear. I think these are questions that still need to be answered.
Yes.
But it appears to show, I was quite surprised, to be honest, to see possible relationship to Meniere's disease, because Fred Linthicum, he passed away recently, but he thought that in some cases virus might be involved, but nobody has been able to isolate the viral particles or visualize viral particles from postmortem studies. But I guess this is one area that needs more investigation.
This is Dorothy. I'm one of the residents. I was wondering, have you or anyone measured the size of the leak in the blood labyrinth barrier? Like what size, like in nanometers, that things would pass through?
No, I don't know. I don't know. I don't know. I don't know the answer to that.
Okay.
Somebody may have done, such studies, but I am not aware of it offhand.
Well, thank you so much for your time. I know you and I have been planning you to give a talk here for quite some time, even before COVID. I really appreciate it. I know you're so busy, and you're just doing really important work on a very difficult disease. And I sure enjoyed your words and learned a lot from your talk. So I hope you'll come back and give us another talk in the future.
Thanks, appreciate it. And if your residents are interested in working with us on temple-borne histopathology, as I said, you guys are always welcome.
Thank you so much.
Thanks.
Thank you, Akira.
Okay, bye.
Bye-bye.
Bye.
Okay, great. Well, thank you. Ido or Isabel, are you ready to get started? Perfect. Thank you.
Sure.
Thank you.
Isabel, do you want me to go first?
Either way, whatever you.
All right, cool. I can do it then.
All right, sounds good.
Okay. I'm hoping everybody can see my screen. Is my screen appearing for everyone?
Looks
Yes.
great.
Okay, great. So my name is Ido Badash. I'm one of the first-year residents here in the Caruso Department of Otolaryngology. And I'm going to be presenting on my quality improvement project, which is optimizing postoperative discharge from LAC+USC hospital specifically. It's not the flashiest topic, but I think it's a very important one. So as I think we all know, hospital discharge is one of the most vulnerable points in a patient's care transition, where they're going from the hospital setting where they're constantly surrounded by healthcare providers, including physicians, nurses, and other staff that are tending to their every needs and addressing potential warning signs or complications when they arise. They go from that setting to home or to another facility where they may not have that same level of attentiveness, and that can be pretty scary for patients. Therefore, the discharge of patients, the effective execution of that process has significant implications on a patient's recovery trajectory because, as we know, surgery is not always in itself the cure for a lot of the problems that our patients have, but rather surgery is just the beginning of a long pathway to better health, which includes follow-up visits, medical management, and tests. So all that is to say that the effective communication of discharge instructions to patients is an important tool to promote healing after surgery. So while that makes intuitive sense, I think, to all of us, what evidence is there that hospital discharge after surgery is a significant point in a patient's care plan? Well, I did a literature review, and I found, for one, this study from 2009 in the New England Journal of Medicine, which looked specifically at Medicare patients. They were looking at Medicare claims data from 2003 to 2004, and they looked at over 12 million hospitalizations among Medicare patients, and they found that 51.5% of those who had been discharged after surgical procedures were rehospitalized or died within the first year after discharge. Now, this figure includes a variety of different surgeries that Medicare patients undergo, but it is important to note that the surgeries that compose the largest proportion of these overall cases are surgeries that I would say are more invasive than the ones we undergo in ENT. So vascular surgeries, coronary artery stent placement, and big orthopedic surgeries. Nonetheless, it shows that patients have complications at high rates. There's another study from 2019 out of Australia and New Zealand, which identified that after postoperative discharge with 2-week and 2-month follow-up, over 36% of patients experienced complications. And they also looked at quality of life and satisfaction scores with validated metrics like the SF-36 and Likert scale questionnaires. And they found that these satisfaction and quality of life scores were significantly lower for those with postoperative complications versus those that didn't have them. So I think this evidence points to the idea that it's imperative that we optimize each patient's discharge as an opportunity to address complications and improve patient care. So what factors are actually important to optimize in the post-discharge process? Well, there's an interesting study out of the Canadian Medical Association, the counterpart to the American Medical Association, from 2019. They looked at patients' and caregivers' perspectives on factors that influence patients' understanding and adherence to discharge from the hospital after surgery. And they collected data using semi-structured interviews from 3 different hospitals in Ontario. And based on the information they got from patients, they were able to come up with 5 different themes or categories of comments from patients that seemed to influence the study subject's understanding of and adherence to discharge instructions. So ordered in terms of the most frequent to the least frequent, these are factors related to the delivery of discharge instructions. So things like rushing while giving discharge information, missing important discharge instructions, addressing or not addressing possible complications, never receiving discharge instructions, or not having the opportunity to clarify instructions that they weren't sure about. The second most frequent was barriers to accessing post-discharge care. And this means both physical barriers in the sense that patients were not able to either afford their continued follow-up or attend the follow-up visits due to transportation, but also not having the contact information for their physician, not knowing who they could contact during business hours, after business hours, in order to actually make appointments and be followed up. Other themes that they reported were confusion about the perceived role of their providers. So oftentimes surgical patients have a variety of different consultants, providers, nursing staff that take care of them in the hospital, and as well as in an outpatient, and they're really not sure what the role of each and degree of responsibility is for these patients' care among each of these different providers. And specifically, they expressed some confusion about their relationship with inpatient and outpatient provider. So who's really responsible for their care now? Is it their surgeon that they're going to be following up with after discharge? Is it their primary care provider? Is it some other outpatient provider? And finally, patients reported that their experience while in the hospital also affected their adherence to post-discharge instructions. So how well they thought they were getting taken care of and how well they thought their surgery went. So the problem that I've identified at LAC+USC is that at our hospital, patients are typically scheduled to follow up as outpatients for a variety of different reasons, post-op checks, further evaluations, diagnostic tests after surgery. And on many of these follow-up visits during my rotation and from talking to some of the residents that are there now, we found that patients disclosed that they were not adherent to post-surgical care instructions. And it's not because they didn't want to, but it's because, for one thing, they will say that their post-operative instructions were oftentimes not clear, or they never received these instructions. In some patients, we've had situations where they've followed the wrong instructions because standard patient instructions after surgery were given to them that do not apply to their specific procedure and their specific care plan. So addressing different types of packing that they may have received, different types of incisions, or other nuances that make, even though there's one specific type of surgical procedure, having that surgery be different amongst different patients. So clearly there's some sort of breakdown in the communication between providers and patients at LAC+USC oftentimes. So my overall plan for the quality improvement project is going to be shown with the diagram that I'm going to have popping up incrementally on this slide. So I've identified what I think is a problem, which is that there are some gaps in communication between patients and their provider at the point of hospital discharge. My goal is then to optimize these discharge instructions through a variety of different mechanisms that I'll be speaking about. It's important that I ensure that faculty and residents are able to actually execute on this plan and deliver these new materials to their patients. And the goal that I have in mind is to overall have improved patient understanding of and satisfaction with post-discharge communication. And of course, to see if I'm successful at this task, I need some sort of objective measurement of outcomes. And what I'm hoping is based on these measurements, I can then collect further information, which is going to help me identify additional gaps in communication, which I can then again act upon, tailoring discharge instructions, carrying these out, and measuring the outcomes once again in a continuous cycle. So the key components of discharge instructions that I've identified, again, by speaking with Dr. Chambers, as well as talking with many of the residents at LAC+USC, is that discharge instructions should be given in plain language and in a patient's native language. So they need to understand what type of postoperative care they are responsible for at home and what warning signs may arise in a plain way that they can all understand, regardless of their health literacy. They need to have some sort of explanation of the procedure that was performed, so they know what kind of surgery they underwent and how to take care of themselves after. Key frequently asked questions should be addressed regarding any symptoms that may arise or potential warning signs. They should also be given with reasons to present to an emergency room, as well as to an urgent care center for any potential warning signs that need to be acted upon rapidly. And finally, they need to have contact information to be able to get a hold of a medical provider that knows about them during business hours, as well as having numbers and options for medical contact after hours as well, because oftentimes emergencies or urgent matters can arise after business hours as well. So the first step of my quality improvement project is actually just creating this simple LAC+USC hospital discharge face sheet. And I was surprised that we don't already have something like this, but I think it can be very important. So what this face sheet is going to include is when the follow-up appointment for patients is going to be scheduled for. So they have that right at the top and know where and when they're going to be following up. And the next few lines are specific contact informations in different situations. So the first line, in case patients need to reach one of their physicians for a medical question during business hours, they can call our clinic between 8:30 a.m. and 4 p.m. on weekdays, and I've provided the number for that. Additionally, what I've found is that oftentimes our patients just don't know who to reach after hours, and they'll just present to the emergency room because they don't know where else to go or who to talk to. So I've also provided them with the number for the 7G nursing staff for them to contact after business hours. And this is something that I discussed with Dr. Chambers as the 7G nursing staff having the capacity to handle these phone calls. So that's the number that is written on the second line. For the third line, I've included that if patients need to be seen urgently, they should present to the urgent care center at LAC+USC or another urgent care center near them. And I've included the regular hours of operation for the urgent care. And finally, if they felt that they have an emergency, I've included they should present to the emergency department at LAC+USC, which is open 24 hours a day, 7 days a week, or any emergency department that is near them. And in terms of actually explaining to patients what is an urgent matter and what is an emergency, that is something I'm going to be talking about later in this presentation. So my initial focus, besides this face sheet, is I want to update the discharge instructions for some of the most common surgeries that we perform at LAC+USC as a starting point. So after speaking with some of the residents, as well as Dr. Chambers, I've identified these three surgeries, so tympanoplasty, direct laryngoscopy, and tonsillectomy, as some of our most frequently performed procedures. Now, ordinarily, when patients are set to be discharged from LAC+USC, and actually this applies to Keck Hospital as well, we are able to have our nursing staff print pre-generated discharge instructions from this repository, which is built into Cerner, which I believe our hospital or Cerner has partnered with this Staywell company, which is a third party that produces these discharge instructions. So we can just search in there Tympanoplasty, find the discharge instructions for that, and print them. Now, one of the complications with this project is that there's no great way for our updated discharge instructions to make it onto this repository, at least that we've identified. But one thing that me and Dr. Chambers had noticed is that Harbor UCLA, as well as all of you, were able to produce custom discharge instructions and upload them onto this repository. That's what's shown in this figure here. If I just search Harbor, this is just one example after scrolling a good bit, you can see that there's bronchoscopy discharge instructions Harbor, and it's customized. So I'm going to be working on basically communicating with IT in order to upload our own customized discharge instructions onto this repository. And Or if for whatever reason that doesn't work or we need something in the meantime, I can always upload it to our shared drive that all residents have access to at LA County. So this is an example of discharge instructions for Tympanoplasty, which is available on this online repository from Cerner. And you can see that it does include a good amount of useful information for patients. So it talks about what the procedure was. So it's Tympanoplasty is fixing a damaged eardrum, stopping infection, or improving hearing. And they give some instructions for home care. And a lot of useful information is included, like not doing anything to make the ears pop, not performing any activities that involve heavy lifting or straining, sneezing with the mouth open as to not Valsalva, showering as needed, keeping the ear dry, getting healthcare providers permission before performing strenuous exercises, expecting a small amount of drainage from the ear, not to be alarmed if the skin of the outer ear is numb, and to take medication as it was prescribed by the provider. And it also provides this little tidbit on the right, which is when to seek medical care. And the instructions just say to call your healthcare provider right away if you have any of these. And then it lists some generic problems like ear pain, problems with balance or walking, redness or swelling around the ear, dizziness, and other signs and symptoms you can see here. But I'll say that one of the problems with these discharge instructions, besides the omission of what I think is some key information, it doesn't really clarify how these medical warning signs or signs or symptoms should really be triaged as far as, are these urgent matters? Are these emergent matters? And are these things that you actually even need to contact your physician about? So the way to address that is, I think, including more plain and simple information, as well as giving our patients information on how to triage these warning signs. So some additional instructions, just as an example, I'm hoping to include. And again, this is based on frequently asked questions that after speaking with residents, I've realized they're regularly getting called about or hearing about in the clinic when these patients follow up. So the first of these, do not remove any packing in your ear canal, as this will dissolve or be removed by your surgeon at your next visit. Patients should be instructed that a small amount of drainage from the ear or the incision is normal after surgery, and that this may be blood tinged, because we often get calls about bloody, slow secretions from the ear or incision. If a small amount of bleeding occurs from the incision, they can tape a small piece of gauze over it to collect drainage. And if it doesn't stop with gauze or pressure application, they can call their doctor or present to an urgent care center. After surgery, it's normal for the ear to feel full or for hearing to be worse because of the packing, and this should improve with time. It's normal to feel slightly dizzy or have taste disturbance after surgery, and these problems will generally resolve on their own. And I think one of the most important parts is clarifying what requires emergency care, urgent care, and what requires a call to a doctor. So I would want to list that some emergent signs that should cause the patient to present to an emergency department are chest pain, shortness of breath, syncope, facial droop, double or blurred vision, foul-smelling purulent discharge from the ear or incision. Signs or symptoms that might require a visit to an urgent care are slow oozing from the ear or incision that is bloody, that does not stop after a few minutes with pressure application, as well as fevers without any other signs or symptoms. And then patients should be instructed to call their doctor, preferably during business hours, for any other warning signs that weren't addressed on this sheet. Looking at some of the other procedures that I've identified, for direct laryngoscopy, I want to clarify that a sore throat, pain with swallowing, or pain with speaking and hoarseness are common following surgery and may last 1 to 2 weeks, as this is a frequently asked question. When returning home, patients should start with ice chips and sips of water, progress to eating soft foods like Jell-O, yogurt, or mashed potatoes as tolerated, until they're able to tolerate more solid food. So this gives patients a little more information about their diet after surgery. And finally, I want to instruct them that if lesions were removed from the vocal cords, they may have to follow total voice rest for up to 2 weeks or as instructed by their provider. So again, these are a piece of information that were omitted from the standard discharge instructions that are available on Cerner. For tonsillectomy, I want to instruct them that when tonsils are removed, it usually takes 2 to 3 weeks for the throat to stop hurting, for appetite to return, and for complete recovery to occur, as patients oftentimes wonder why they're not feeling better just a few days after surgery. I want to tell them about the scabs that they may see in their mouth. So there will be 2 white areas, most likely where the tonsils were removed, and they should avoid coughing, throat clearing, or nose bleeding, or nose blowing in order to avoid loosening up the scabs and causing bleeding. Again, I want to clarify diet instructions, so drinking plenty of cold water, since that is really important after tonsillectomy, and eating soft foods like yogurt, gel, or mashed potatoes for the first 1 to 2 weeks after surgery. And then one problem that we often get called about at LAC+USC is when patients have increased pain 1 week after surgery because the scabs may have come off. So I want to specifically instruct them about this potential problem that may arise so that they're not confused or scared when this happens. And let them know that when these scabs do come off, that there will be some bleeding, but it usually stops in a few minutes. And then again, I'm going to provide instructions about what is the emergency, what's an urgent matter, and when to call a doctor, specifically calling a doctor or presenting to the emergency room for any bleeding that does not resolve on its own in a few minutes, and distinguishing those based on the amount of bleeding that occurs. So those are kind of the discharge instructions that I'm going to be tailoring for those specific surgeries. And I'm going to continue collecting information from residents as well as faculty members to obtain additional instructions. But I also want to emphasize to our residents that specific instructions that are tailored to the individual patient should also be included on these discharge sheets. And what's nice about this repository of discharge instructions is that each individual sheet is fully customizable in that you can add additional information to it without a problem. The issue is that you can't save that customized sheet, but you can certainly edit a sheet and then print it. So at the bottom, I want to include a customized portion, and I want to point patients' attention to this customized part, where residents should be including aspects unique to each patient's care, like whether they receive dissolvable versus non-dissolvable packing, having specific diet plans if they weren't mentioned already, and clarifying drain care for those patients that go home with a JP drain, a Penrose, or something else. And this information should also be included in a patient's discharge summary so that it can be accessed by other residents or faculty other than the operating surgeon in case they're the ones that are called by the patient when the operating surgeon isn't around. And some residents, I will highlight that some residents already do this, and others include these discharge instructions in other various portions of Cerner, such as the discharge instructions tab or somewhere else. But I think just emphasizing a standardized central way to have all these customized instructions on these sheets, I think is going to ultimately just ensure that our patients are able to receive these instructions in a systematic and basically surefire manner. So the final component of my QI project is I want to actually assess how patients feel about undergoing surgery at our hospital and whether this quality improvement project and these interventions are making any difference at all. So for that purpose, I've developed a 5-point Likert scale questionnaire. I'm going to translate to several languages. It's already been translated in Spanish that we're going to administer at the first follow-up visit for patients. And I want this to be a really simple questionnaire that includes questions that pretty much patients with any degree of health literacy should be able to answer. And for those that don't know, a Likert scale typically includes 5-point Likert scale usually includes the options strongly agree, agree, unsure, disagree, or strongly disagree, or some variation of that. So the questions will be, I understood the procedure that I underwent well. I understood what my instructions were for postoperative care. I understood what is considered an emergency and what to do if I have one. I felt comfortable going home after surgery. And overall, I'm happy with my transition out of the hospital after my operation. The next step is once I've developed this questionnaire and administered it to patients, I also want to make sure it's administered to patients that didn't receive, whose discharge instructions were not optimized through this quality improvement initiative. So I'm going to look at other outpatient surgeries which are similar in degree of, I guess, invasiveness or intensity of postoperative care. So things like septoplasty, rhinoplasty, stapedectomy, and small facial fracture repair. Understanding that undeniably there will be some confounding variables, considering not all of the standard discharge instructions have the same quality. For example, for some of these surgeries, they may already be of a high quality, or the discharge instructions may be just more intensive or complicated. But nonetheless, I think this is a good way to start at comparing groups. And then I basically want to compare the questionnaire results between these groups to assess for any improvement in patient satisfaction after my interventions. And I want to use the results of this comparison to guide further changes and tweaks to discharge instructions. So just going back to my original flow diagram, if you look at the bottom, the measurement of outcomes, once I'm able to actually assess these variables, I can then hopefully identify additional gaps in communication and use these to further tweak our discharge instructions and carry the cycle forward once again. So in conclusion, I believe that a successfully planned and executed post-surgical discharge is important to patients' continued recovery and the fulfillment of their care. And I think the post-surgical discharge instructions at LAC+USC Hospital can be improved, and there is a lot of room for improvement in order to optimize care for our patients. And I'm hoping that continual assessment of the impact of these interventions through my Likert scale questionnaire can guide future changes in order to incrementally improve the discharge process. So I'd like to thank the people here, Dr. Chambers for helping me design this quality improvement project and further flesh it out, Shane, Stephen, and Peter for giving me a lot of really great information about frequently asked questions from patients and just helping me really develop this quality improvement project. And Angela Lustre, who is our surgical coordinator at LAC+USC, who also provided me with some great information regarding the types of questions she frequently gets when she is called by our patients. These are my references for anybody who's interested. I would be happy to send these over to you. And that's it. So does anybody have any questions?
Ido, yeah, nice job. Thank you. Your project was much larger than just the post-operative instructions and guidelines, but if you need those, I mean, we've developed them for the otology division for every surgery, and we have a handout we give patients with it, and I have it all in Word document. So,
Yeah.
and I suspect most other divisions have already created this as well, because you know, at Keck we have the same issues, right? So we give handouts to our patients.
Right. Yeah, I would love to get those from you.
We have some for head and neck. I don't know if we're using them anymore, but we made them a while back.
Yeah, that sounds good. And I think after we see whether these interventions are effective at LAC+USC, and you know, a reasonable option is to see if these interventions can be incorporated on the Keck Hospital side as well.
Okay, I can
Thank
start
you.
to share my screen. Thanks, Ido. That was great.
Thanks, Isabel.
Can everyone see my screen?
Yes, looks good.
Great. So good morning, everyone. My name is Isabel Magro, and I'm one of the ENT interns. This morning, I'm presenting my quality improvement project, which involves creating an ENT resident pocket guide. I wanted to start by framing my talk in the context of the 6 aims of quality improvement in healthcare. Initiatives in healthcare should aim to improve practices that are safe, effective, patient-centered, timely, efficient, and equitable. I created my quality improvement project with these principles in mind, and I will circle back to them at the end of my talk. I have an interest in medical education, so I decided to create a quality improvement project related to residency training. I thought about the overarching goals of a residency program, which are to train highly skilled physicians and surgeons. This applies to our own residency program, whose objectives are outlined in the current slide, which is from our website. As an intern, I thought about how to achieve these goals in the context of transition periods during training. At the beginning of the year, I found myself on a steep learning curve transitioning from a medical student to an intern, while also learning my way around a new hospital. My questions included where to find the cafeteria, how to order insulin sliding scale, which happens to be different at Keck and County, our protocols for flat post-op care, and the approach to an acute tracheostomy bleed. Unsurprisingly, I found that my co-interns, both within the program and among other specialties, had similar questions. But I also noticed that among the residents more senior to me, each year had their unique set of questions as they also entered a new role with new responsibilities and challenges. I also noted that they had to refamiliarize themselves with procedures at Keck versus county and vice versa. The learning curve for each year of residents, particularly the junior residents, has prompted studies examining the July effect. This is a phenomenon in academic medicine that refers to the influx of new trainees and the subsequent presumed effects on the quality of patient care and health outcomes. Here on this slide, this is a systematic review by Young et al., which examined 39 studies, of which 69% reported mortality, 49% reported efficiency, which was defined as length of stay, duration of procedure, and hospital charges, 59% reported morbidity, and 15% reported medical error outcomes. All studies focused on inpatient settings and predominantly examined these outcomes among internal medicine programs. The study concluded mortality increases and efficiency decreases in hospitals because of year-end changeovers. Although heterogeneity in the existing literature does not permit firm conclusions about the degree of risk posed, how changeover affects morbidity and rates of medical errors, or whether particular models are more or less problematic. Since then, other studies among the surgical subspecialties, including plastic surgery and neurosurgery, have examined this effect and have reported minimal evidence of the July effect. They conclude that overall, the current resident training system provides enough guidance and support during this challenging transition period. In addition to oversight by more senior residents, hospitalists, co-management, and attendings, how do we maintain quality patient care during this transition? Much of this depends on our own self-learning. We have resources within otolaryngology, including Pasha for an outline of clinical practice, and Cummings and Bailey's for a deeper dive on clinical practice. These are robust resources that help with overall medical and surgical knowledge. However, they may not be the easiest to navigate when you're looking for a quick answer to a question. They also often provide multiple options for management, which are undoubtedly important to consider. However, often programs such as ours have our own tailored stepwise approach to a clinical presentation, which cannot be gleaned from these resources. And finally, these resources also do not include a guide to our hospitals, including the differences in workflow at Keck and LA County. To address this, our department has created some guides and notes that have been shared. We have Dr. John's sub-I guide. We have an intern guide to county ENT, which was updated recently by Shane. We also have Apple notes, such as the one pictured on the slide, that includes useful phone numbers at Keck. These resources are incredibly helpful, but they are not integrated into centralized resource, and they are most robust to provide guidance for the intern at county. This brings me to my quality improvement project, which is to create a USC OH&S residency-specific integrated resource that orients residents to hospital-specific and rotation-specific procedures, provides a foundation of knowledge for OH&S-related patient care, examines the eases the academic end-of-year transition, and improves efficiency. This is not intended to be a comprehensive guide to otolaryngology, but a starting point from which residents can transition through the stages of the hierarchy of competence. This guide is mostly targeted at the transition from unconscious incompetence to conscious incompetence. After all, it's hard to know what you don't know, especially at the beginning of residency. But this guide aims to provide a practical introduction to topics in management residents need to learn more about, and provide logistical tips that aid in providing patient care within the hospital systems. It will therefore benefit the junior residents the most and make them more efficient during these transition periods. The sections of the pocket guide are outlined above. These include 1, orientation to the hospitals, including a map, directions, instructions for parking, orientation to rotations, including their structure and responsibilities. It will also include practical logistics, including useful numbers for consult services and units in the hospital, and instruction regarding how to perform tasks such as how to book a patient for surgery or fill out a Medtronic form for someone to come into the OR, or order a CD for a sinus case. It'll also include inpatient management topics, including postoperative care, such as our free flap protocol, the most common floor calls we get, and hospitalist co-management guidelines. It'll also include information about clinic, including the workflow, most common visits within the subspecialties, and it'll also integrate clinical practice guidelines issued by the Academy. In addition, there'll be a section on procedures and surgeries, including preparation setup for cases and potentially attending preferences as well. And the last portion will be a guide to consults, including the most common at Keck and at County, which is aimed to benefit the PGY2s the most, but can also benefit interns as they start to take on those roles. In the next few slides, I've provided examples of content that will be included in each section. In the first section on orientation, it'll include information that should be gained before your first day at Keck and at County. Here I've included information about Keck, about how to submit the application for parking and who to contact to ensure that your ID is activated, where to find scrubs, how to gain remote access for Cerner, and creating an account that enables you to provide consents. At County, there are similar components, including getting access to parking and who to contact, but also how to obtain your keys to the bathroom, clean utility, and the resident room in the ENT clinic at County, which can all be obtained from the locksmith shop, which is in the old County building. It also includes where to find scrubs and also how to interface with IT in order to gain access to important functions that you need on your first day, such as the shared drive, case selection, and perioperative tracking. These processes are similar at both hospitals, but have their own quirks that are helpful to know before your first day. This section will be expanded to include important contact numbers for units and services at both hospitals, as well as codes to get access to certain areas of the hospitals, particularly at Keck. The next section is inpatient management. Here I've outlined our free flop protocol, including anticoagulation use, antibiotic use, sedation and ventilation after the OR, flap checks and how these change during the postoperative period, length of ICU stay, tube feed instructions, wound care guidelines, and disposition. This section will also include our other protocols, for example, our thyroid and parathyroid surgery protocols and our rhinology postoperative care. This section will also include a guide to the most common floor calls, including pain, arrhythmias, hypoxia, bleeding, blood glucose management, decreased urinary output. And finally, it'll outline guidelines for interfacing with hospitalist co-management. The next section is the clinic section, which will act as a starting point to learn the approach to the most common clinic visits among the subspecialties, while also integrating clinical practice guidelines published by the Academy. For example, I've included an approach to a patient with tinnitus on this slide. It includes differentiation between objective and subjective tinnitus, including its definitions, distinctions on history and physical, and subsequent appropriate workup and management. Other common visits to be outlined include hearing loss, vertigo, global sensation, nasal obstruction. The next section includes procedures and surgeries. One of the most common ones at County is the bedside tracheostomy. This slide describes the preparation required prior to the consultation, including stocking the airway cart and tracheostomy tray. The instructions outline the contents of each of the drawers of the airway cart and which components need to be refilled, as well as the contents of the trach trays that we obtain from the ICU and the items that need to be added to it. The picture on the top right includes all the items that need to be collected to add to the tray. And the image on the bottom right shows the final product when the trach tray from the ICU and the additional components are added together and what it should look like. This section will also include instructions regarding what to do immediately prior to the procedure, including communication with the nursing staff in the form of orders and which medications need to be drawn, as well as what supplies to bring to the bedside and how to set up the room and prep the patient prior to the procedure. Other procedures that will be included in this section include instructions for PE2 placement on an awake patient, epidermoid cyst removals, and also how to set up for surgeries, including attending preferences. The next steps for this project include expanding each section to produce a final product of the pocket guide, asking senior residents and attendings to review the guide, uploading the document to a shared Google Drive that can be edited for future years and added to if other components seem to be useful for future residents, and to print a spiral-bound physical pocketbook that can be handed out to residents yearly. This can be done in a pretty cost-effective manner by allowing FedEx or other similar companies to print it. I'd like to close this talk by circling back to the 6 aims of quality improvement in healthcare. I believe that this quality improvement project promotes patient care that is safe, efficient, and equitable as it provides consistent guidelines to residents, effective as it integrates clinical practice guidelines, and timely as it provides residents with answers to basic questions quickly without having to ask a more senior resident. This QI project does not directly address the patient-centered aim, though it always is important to incorporate it in daily interactions with patients. Thank you for your attention, and a special thank you to Lavisha and Shane for their input into this project and for providing some initial resources to get the pocketbook started.